trying to truly fix a joint after an injury feels like it should be straightforward in the 21st century, doesn't it?
It really does feel that way sometimes.
But think about this. Even, a seemingly small tear in the ankle's delicate network of ligaments, or maybe a subtle rip in the hip labrum can fundamentally change how forces travel through the joint.
Absolutely. It
Yeah.
can lead to complex long-term issues down the line.
Or consider knee replacement. After all that sophisticated surgery, replicating the fluid, natural motion of your original knee, well, it remains a significant challenge.
That's right. It often limits the very activities patients hope to return to.
So why is it so incredibly difficult to perfectly fix a joint once it's damaged, to fully restore its native function? What intricate secrets do our body's own mechanics still hold that perhaps evade our best repair efforts? Welcome to the Deep Dive. We take stacks of information from dense textbooks to cutting-edge research and distill the most important nuggets of knowledge to help you get well-informed fast.
A valuable service.
Today, we're plunging into the absolutely fascinating world of orthopedic biomechanics. Specifically, we're zeroing in on how these mechanical principles govern sports injuries and how we attempt to fix them.
A complex and crucial area.
Our guide for this journey is a foundational source, a comprehensive textbook, Orthopedic Biomechanics in Sports Medicine, put together by a global collective of leading experts.
It's a really thorough piece of work.
And to help us navigate this wealth of information and unpack the key insights for you, we have our expert guide today. He brings deep expertise in biomechanics and, a remarkable ability to synthesize complex material into understandable concepts.
Happy to be here and dive into it.
Great. Thank you for joining us. Let's maybe kick off with a few rapid-fire questions straight from the core of this material just to set the stage.
Okay, sounds good.
From the foundational chapters of this textbook, what's one fundamental principle of biomechanics that someone absolutely must grasp to understand how our joints cope under load?
It's really about the material properties. You have to understand them.
Right.
Each tissue type in a joint bone, ligament, tendon, cartilage, behaves uniquely under stress. Understanding how, say, ligaments resist tension or how cartilage handles compression through its sort of biphasic nature, that's utterly fundamental.
Right.
You really can't appreciate the resilience or vulnerability of a joint without knowing the inherent strengths and weaknesses of its constituent parts. The building blocks, as you might say.
That makes intuitive sense. The building blocks definitely matter. Now, when we talk about repair, the book details techniques for different tissues. Is there a core biomechanical challenge that just crops up again and again, regardless of whether you're trying to fix a ligament, a tendon, cartilage, or maybe using a bone graft?
Yes, that's a crucial point, actually, about restoration versus replication. The consistent challenge is that biological repair, or even surgical reconstruction, it rarely perfectly replicates the native tissue's original mechanical properties, or its intricate architecture.
So it's never quite the same.
Exactly. We often end up with scar tissue or perhaps replacement material that's mechanically inferior or sometimes just different. And that impacts how the joint functions under stress compared to how it was before the injury.
And technology plays a growing role here, doesn't it? The source highlights tools like finite element analysis, FEA. How is that fundamentally changing how we approach understanding and treating joint injuries?
Well, FEA is a bit of a game changer. It allows us to create these sophisticated virtual models of joints and then simulate how forces and stresses distribute within them.
So you can test things out virtually.
Precisely. We can test hypotheses about injury mechanisms, we can evaluate surgical plans before cutting any tissue, or predict how implants will behave under load. It provides insights we simply couldn't get from, say, physical tests or imaging alone. It offers a predictive power that just wasn't available previously.
Fascinating. Finally, this material dives into the specifics of different joints. Why does paying close attention to incredibly subtle anatomical details, things like specific ligament attachments or the precise shape of a joint surface, become so critical when dealing with injuries in areas like the shoulder or ankle?
It's because joints are systems of, carefully balanced constraints and motions. Think about the ankle.
Okay.
The specific orientation and tension of tiny ligaments dictate stability through a full range of motion. In the shoulder, it's the dynamic interaction of muscles and the subtle angulation of the glenoid socket that are key.
So the small stuff really matters.
Absolutely. Small anatomical details aren't just academic points, they're biomechanical levers. If you disrupt one small part, it can have disproportionate effects on the entire joint stability and its load-bearing capacity. And that predisposes it to, further injury or degeneration down the line.
Those rapid-fire points really underscore the complexity, don't they? Let's dive deeper into that first area you mentioned. The foundational understanding of how these distinct tissues behave under load. The textbook makes it abundantly clear these aren't just passive materials. They have active, measurable biomechanical personalities.
Absolutely. And understanding these personalities, as you put it, is the starting point for everything else. Take ligaments, for example. Their primary job is to resist tensile forces, so pulling or stretching. Think of them as biological ropes that check or limit excessive joint motion. They have a specific stress-strain curve, showing how they elongate under load before, well, ultimately failing if the load is too high.
And the book details how surprisingly difficult it is even to measure that strength accurately in a lab setting. Why is that?
Well, what's fascinating here is the practical challenge. How do you grip a soft, complex biological tissue without damaging it or having it slip?
I can see how that would be tricky.
It is. If your clamps are too aggressive, you induce stress concentrations right there at the clamping site. Then the ligament fails there, not in the mid-substance where you want to measure its true properties.
So how do researchers get around that?
They use clever techniques, things like serrated clamps or embedding the ends in resin and then freezing them, or even non-contact methods using markers and cameras to track deformation along the ligament's length, all trying to get an accurate picture of its real behavior.
And their healing process, it's notoriously slow and often imperfect, leading to scar tissue. What's the biomechanical and biological reason for that slowness?
Well, their biology really dictates it. Ligaments have relatively low cell density, and they're hypovascular, meaning they have a limited blood supply compared to, say, muscle tissue.
Ah, okay.
This restricts the delivery of healing factors and cells needed for repair. The healing process itself, as described in the source, follows a four-phase cascade: initial bleeding and inflammation, then proliferation where fibroblasts lay down a temporary matrix, and then a very long remodeling phase.
And that remodeling takes a long time.
It does. Crucially, the new matrix laid down is often primarily weaker type 3 collagen initially. That's only slowly replaced by the stronger type I collagen found in the native ligament. This remodeling and reorganization into properly aligned fibers under load takes months, sometimes even years. And the result? Often tissue that is mechanically inferior to the original.
So it never quite gets back to 100%.
Often not. The MCL, the medial collateral ligament in the knee, is a classic example. It's an extra-articular ligament outside the joint capsule, and it follows this relatively slow but often quite successful healing pathway. However, even then, the healed tissue is still biomechanically different from the native ligament.
That difference between the original and the healed tissue seems like a recurring theme, doesn't it?
It really is.
Moving on to tendons, they seem built differently to handle load.
Tendons are primarily designed to transmit forces from muscle to bone. Their structure reflects this. They are highly organized, almost modular units.
Oh.
The basic building block is the type I collagen triple helix. These aggregate into fibrils, which then bundle into fibers and then into fascicles. It's this hierarchical structure that allows them to be so strong under tension.
Right.
The source points out the concept of load capacity, the amount of force a tendon can withstand before damage. And this capacity varies massively between individuals.
Depending on activity levels.
Exactly, which is why the patellar tendon of a professional weightlifter is dramatically different biomechanically from that of a sedentary individual. It's adapted to handle much higher stresses through remodeling.
And there's an interesting hypothesis mentioned about the different types of collagen fibrils within tendons.
Yes, the textbook discusses this idea that tendons contain both large and small diameter collagen fibrils. The hypothesis is that the large fibrils are the primary load bearers, resisting that tensile stress.
And the smaller ones.
The smaller, perhaps newly synthesized fibrils might play a role in repairing microdamage and supporting the structure between the larger fibers. It suggests this ongoing process of adaptation and maintenance happening within the tendon structure, constantly responding to daily loading.
Fascinating. Let's shift to cartilage, that smooth, shock-absorbing material on the ends of our bones. It's described in the book as a biphasic medium. What does that mean, and why is it so crucial for its function?
Biphasic essentially means it has two phases. There's a solid phase made up of collagen, proteoglycans, or PGs, and chondrocytes. Those are the cartilage cells.
Okay.
And then there's a fluid phase, which is primarily water. This structure is absolutely key to how it handles compressive loads, like when you step or jump.
How does that work?
Well, compression is resisted by two main mechanisms. Firstly, there's a flow-independent mechanism. This comes from the negative charges on the PGs, which repel each other within the collagen network, resisting collapse.
Okay, sort of like internal springs.
In a way, yes. But secondly, and perhaps more importantly, there's a flow-dependent mechanism. When you compress cartilage, the fluid in the tissue is squeezed out through the solid matrix and across the articular surface.
Right.
Now, because cartilage has very low permeability, this fluid flow is slow. That creates a frictional drag that resists the compression. This is known as viscoelastic behavior. Essentially, the tissue's time-dependent response to load due to that fluid movement. It's vital for absorbing impact and protecting the solid matrix from excessive stress.
So it's not just a simple cushion, it's more like a very stiff, slow-moving, fluid-filled sponge that dissipates energy.
Exactly. That's a very good analogy. That fluid phase and its controlled movement are critical for protecting the solid framework.
Now, bone grafts are another essential tool in orthopedic surgery. The source goes into detail about different types and why autograft is often called the gold standard.
Yes, autograft is using the patient's own bone.
What makes it the benchmark?
It's because autograft inherently possesses all three key properties needed for optimal bone formation. First, osteogenicity. It contains live bone-forming cells.
Okay.
Second, osteoinductivity. It contains growth factors that signal surrounding cells to become bone-forming. And third, osteoconductivity. It provides a physical scaffold for new bone to grow across.
Plus, it's your own tissue.
Exactly. So it's histocompatible, non-immunogenic, and carries minimal risk of disease transmission or infection compared to using donor bone.
What about allografts, then, from a donor? They seem necessary when a lot of bone is needed, but they come with different challenges, right?
They do. Allografts from deceased donors are widely used, especially for larger defects, but they do carry theoretical risks of immune reaction and disease transmission, although modern tissue banking processes have really significantly reduced these concerns.
But the processing affects the bone.
Yes, that's the trade-off. These processing methods, like freezing or freeze-drying while enhancing safety, can also reduce the graft's biological activity. They might damage or remove those osteogenic cells and potentially reduce the osteoinductive signals.
So less biologically active.
Potentially, yes. So there's an inherent trade-off between safety and preserving that biological potential for bone formation. Structurally, allografts can provide immediate mechanical support, but processes like freeze-drying, while great for storage, can reduce the bone's mechanical strength. The source cites a figure of around a 20% reduction.
Wow, 20%.
It's significant. So you have to weigh the need for structural support against the desire for rapid biological incorporation when choosing.
And the newer options like cellular allografts and capsuminous, how do they fit in?
Cellular allografts are an attempt to bridge that gap. They provide a scaffold along with live mesenchymal stem cells, MSCs, from a donor aiming for osteogenicity without needing to harvest the patient's own bone.
But they have hurdles.
They do. Because they contain live cells, they require much more stringent screening and face greater regulatory hurdles. Calcium phosphate, or CAMP cements, are synthetic materials. They're primarily used as osteoconductive scaffolds to fill bone voids. Their mechanical properties depend a lot on their composition and porosity. Some are designed to be more porous and resorb faster, but they tend to lose strength as they resorb.
So lots of factors to consider.
Definitely. Selecting the right graft material involves a careful consideration of all these biological and mechanical properties, the required structural support, and the compromises involved in each option.
Fascinating how even the material choice is such a complex biomechanical calculation. You briefly touched on muscle actions earlier, noting eccentric actions are more injury-prone.
Yes, eccentric contraction, that's when a muscle lengthens under load, like lowering yourself slowly into a squat, is critical for controlling movement and absorbing shock.
But riskier.
It generates higher forces per unit area within the muscle and tendon compared to concentric or shortening actions. So if the load exceeds the tissue's capacity during a rapid or uncontrolled eccentric movement, it significantly increases the risk of muscle strain or tendon tear.
Right. All of this fundamental understanding must feed into how we actually analyze mechanics. And that's where finite element analysis, FEA, comes in. Could you elaborate on how FEA, which sounds very much like an engineering tool, became so crucial in orthopedics?
Well, FEA was indeed developed in structural engineering, analyzing complex loads on things like bridges or airplane wings.
Right.
But biological structures like joints and bones with implants are also complex structures subject to complex loads. FEA allows us to create a virtual 3D model of, say, a femur with a hip implant.
Okay.
We then discretize this model, essentially break it down into millions of tiny geometric elements, each connected at points called nodes. We can then apply boundary conditions and loads to this virtual model, mimicking physiological forces like muscle contraction or weight bearing.
Simulating real-life stresses.
Exactly. The software solves complex equations at each node to calculate the resulting stress that's force per unit area in strain, which is the deformation.
So it's like creating a detailed stress map of the bone or joint.
Precisely. This stress map shows us where forces are concentrating and where the tissue is deforming the most. This is invaluable in orthopedics.
How is it used specifically?
We use it to predict how different implant designs will affect stress distribution in the surrounding bone, which is absolutely key for preventing loosening or fractures later on. We can analyze the biomechanical changes caused by different surgical techniques, or even optimize the design of orthopedic devices like splints or braces by modeling their force displacement characteristics.
What are the main hurdles in using FEA clinically? It sounds powerful, but maybe complex to implement.
It is powerful, but there are challenges. The main ones mentioned in the source are the sheer complexity of biological tissues and their properties. They can vary significantly between individuals. Then there's validating the models against real-world data, interpreting the massive output of data in a clinically meaningful way, and, crucially, making these tools user-friendly enough for surgeons to use in routine practice.
So it requires collaboration.
Absolutely. It requires close collaboration between biomechanical engineers and experienced clinicians to bridge that gap between theoretical models and practical clinical application.
Understanding those foundational tissue properties and analytical tools like FEA is clearly essential. It provides the context for understanding why joints, which perform such intricate biomechanical balancing acts, are prone to specific injuries. Let's pivot now and apply this lens to some specific examples from the textbook, starting with the shoulder. It's famed for its mobility, but that must come at a cost to stability, right?
Absolutely. The glenohumeral joint, the main shoulder joint, has the greatest range of motion in the body. And that's largely due to its relatively flat socket, the glenoid, and the large ball, the humeral head.
So how does it stay stable?
Stability is achieved through a really delicate balance of static and dynamic components. Static stability comes from things like the bony anatomy, the subtle retroversion or backward angulation of the glenoid and the labrum.
The labrum, that's the cartilage rim.
Yes, exactly. It deepens the socket. And then you have the capsular ligaments, which are particularly strong at the front of the shoulder. Dynamic stability comes from the surrounding muscles, primarily the rotator cuff, which actively compress the humeral head into the glenoid in coordinate complex movements, along with muscles controlling the scapula's position.
The labrum's role seems more significant than just being a simple rim. The source mentions the concept of a suction seal. Can you explain that?
Yes, the labrum is crucial. It definitely adds to the socket depth. Howell and Galliant quantify that contribution, increasing the bony congruency, but it also works with the joint capsule to create a negative intra-articular pressure, essentially a suction seal.
Like a vacuum.
Pretty much. Studies, particularly in hip, which has a similar mechanism, have shown this suction seal provides a significant portion of the joint's resistance to distraction, especially in the initial millimeters of movement. So a labral tear disrupts this seal, immediately reducing that passive stability and altering the joint's kinematics, even if the bony structures themselves are intact.
So a labral tear isn't just a structural defect, it's also breaking a crucial biomechanical vacuum. Wow.
Exactly. It changes the subtle mechanics of how the joint moves and loads. When this overall static and dynamic balance is disrupted, that's when you see problems like glenohumeral instability or rotator cuff tears.
And biomechanics helps explain why these happen.
It does. For rotator cuff tears, the source points to factors like degenerative changes, often starting in what's called a critical zone of the supraspinatus tendon. This area has a relatively limited blood supply, making it more vulnerable to mechanical overload or impingement.
And the specific pattern of the tear matters biomechanically.
Oh, absolutely. Small, isolated tears might have minimal impact on overall kinematics. But larger tears, especially those extending into the subscapularis tendon at the front, can lead to significant superior migration of the humeral head.
Why is that?
Because they disrupt crucial force couples that normally keep the head centered. There's this concept called the rotator cuff cable, supported by cadaveric studies. It highlights that the anterior portion of the rotator cuff acts like a strong cable, resisting this upward translation of the humeral head. If that cable is intact, even with tears behind it, superior migration is limited. But if the tear extends through the cable, the humeral head can rise significantly.
And the thrower's shoulder example is a perfect illustration of how repeated specific biomechanical stress leads to specific injury patterns, isn't it?
It is, absolutely. Overhead athletes like baseball pitchers develop incredible throwing speeds, but it comes at a biomechanical cost.
How do they adapt?
They adapt, for instance, by increasing scapular upward rotation to create more space under the acromion during the overhead phases of throwing. However, the repetitive stress, particularly the extreme external rotation during the late cocking phase, can cause what's called internal impingement.
What's that?
That's where the posterior rotator cuff and the labrum get compressed against the posterior rim of the glenoid. This can lead to injuries like posta lesions, partial articular supraspinatus tendon avulsions, or SLAP tears, which are superior labral tears.
And they can develop other changes, too.
Yes, furthermore, over time, some athletes develop acquired scapular changes. Their scapula might become more internally rotated or tilted anteriorly. This might be a way to compensate for a restricted follow-through motion after throwing. But these altered scapular mechanics can actually reduce the subacromial space, leading to secondary external impingement, the more common type of shoulder impingement seen in non-athletes.
Wow.
Cadaveric studies have confirmed that increasing scapular internal rotation significantly increases contact pressure in the glenohumeral joint itself.
It really is a complex chain reaction of adaptation and potential injury. Moving down to the knee now, ligaments are clearly paramount for stability there.
The knee stability is just a masterpiece of ligamentous checks and balances. You have the collateral ligaments, the MCL and LCL, controlling side-to-side motion.
Right.
And then the cruciate ligaments, the ACL and PCL, controlling front-to-back translation and rotation. The MCL complex on the inside of the knee is particularly robust. It comprises superficial and deep layers, plus the posterior oblique ligament, or POL.
What's its main job?
Its primary role, as the source details, is to resist valgus forces, that's forces pushing the knee inward, and to limit internal tibial rotation. It also plays a secondary role in resisting external rotation and anterior translation, especially when the tibia is externally rotated. Modern reconstruction techniques aim to restore this complex anatomy with multiple grafts to try and achieve near-normal stability.
Okay. And on the outside, you have the LCL and the posterolateral complex, or PLC.
Correct. The LCL resists varus forces, its outward forces. The posterolateral complex is a collection of structures, including the palladius tendon and the popliteofibular ligament, and it works together with the LCL.
What does the PLC do?
This complex is essential for resisting varus stress. It significantly limits posterior tibial translation, especially if the PCL wasn't functional, and it's the primary restraint to excessive external tibial rotation. While its role in limiting internal rotation is smaller, its integrity is critical for overall knee stability, and injuries here often involve multiple structures. It's a complex area.
The ACL and PCL are often talked about as a pair, working together.
They work very synergistically. The textbook mentions the four-bar linkage concept, which is a biomechanical model that helps explain how the ACL and PCL guide the tibia's movement relative to the femur through the knee's range of motion.
So specific roles.
Yes. The ACL is the primary barrier stopping the tibia from shifting too far forward, particularly at lower flexion angles. The PCL is the primary barrier stopping the tibia from shifting too far backward.
And if the PCL is deficient, what are the biomechanical consequences of that?
Well, a deficient PCL results in increased posterior tibial translation. The tibia basically sags backward relative to the femur.
And that changes things.
It significantly alters the loading patterns across the joint. Clinically, you might see what's called a varus thrust gait, where the knee seems to push outwards during walking. But more importantly, from a long-term perspective, this posterior shift significantly increases contact pressures in the medial compartment of the knee and also the patellofemoral joint, the joint behind the kneecap.
And that leads to?
Cadaveric studies have repeatedly shown this increase in pressure. This abnormal loading pattern accelerates cartilage wear, predisposing patients to early osteoarthritis in those specific areas.
Finally, let's consider the ankle, another joint that relies heavily on its ligamentous structure for stability.
Indeed. The ankle joint proper, the talocrural joint, is primarily a hinge joint, allowing up and down movement, dorsiflexion, and plantar flexion. Side-to-side stability is almost entirely provided by the ligaments.
Which ones are key?
The lateral complex, on the outside, consists of three main ligaments. The anterior talofibular ligament, ATFL, the calcaneofibular ligament, CFL, and the posterior talofibular ligament, PTFL. These resist inversion and varus forces, with their specific contributions changing depending on whether the foot is pointed up or down. The ATFL is the one most commonly injured in ankle sprains.
And on the inside.
On the medial side, you have the robust deltoid ligament complex, which resists eversion and abduction. And then slightly above the ankle, the syndesmotic ligaments hold the tibia and fibula together, resisting external rotation of the talus cone within the mortise or socket.
When these ligaments are injured and don't heal well, chronic ankle instability can develop. How does that change the biomechanics?
Well, chronic instability means the normal checks on excessive motion are gone or impaired. This leads to altered gait biomechanics. Studies show individuals with chronic instability often have increased inversion motion during the swing phase of walking and also at heel strike.
And that has knock-on effects.
Yes, this abnormal movement and loading can increase forces transmitted through the lateral side of the foot. It can also lead to compensatory movement patterns higher up the kinetic chain in the knee and hip.
And the source has a really stark statistic about how critical this ligamentous stability is for joint contact. Can you share that again?
Yes, this is one of the most important takeaways regarding the long-term health of the ankle joint. Ramsey and Hamilton's classic study, cited in the source, demonstrated something quite remarkable.
What was it?
They showed that if the talus bone is shifted laterally by just 1 millimeter within the ankle mortise, something that can easily happen with combined ligamentous injuries, like a deltoid rupture plus a fibula fracture, the contact area between the talus and the tibia is reduced by a staggering 42%.
42%, just from 1 millimeter.
42%. Think about that. A tiny shift, barely noticeable visually, nearly halves the surface area over which load is transmitted. This dramatically increases the pressure on the remaining cartilage, accelerating its wear and leading directly to degenerative joint disease or ankle arthritis, much earlier than it would otherwise occur. It really highlights the absolute necessity of restoring anatomical alignment and stability in the ankle.
That 1 millimeter 42% statistic is truly eye-opening. It perfectly illustrates the delicate balance involved. So given this deep understanding of tissue properties, joint mechanics, and these injury patterns, how do these biomechanical principles directly drive the choices surgeons make? And how do they shape the outcomes patients can realistically expect from orthopedic treatments? Let's start with ligament reconstruction, like the ACL.
Okay, when reconstructing a ligament like the ACL, biomechanics heavily influences the graft choice and the fixation techniques used. The textbook compares commonly used autografts, the patellar tendon, or BPTB, and hamstring tendons, HT.
What are the differences?
Well, biomechanical studies show BPTB grafts often have a higher initial load to failure, and they offer bone-to-bone healing, which potentially provides quicker initial stability. However, they can be associated with more anterior knee pain and sometimes patellar stiffness.
And hamstrings.
Hamstring grafts may lead to less anterior knee pain, but historically there were concerns about fixation strength and potential stretching over time. Though modern fixation techniques and using multiple strands like a quadrupled graft have significantly improved this. Long-term studies, including a 15-year follow-up mentioned in the source, suggest comparable laxity rates between HT and BPTB over the long haul, but differences in other outcomes, like pain or kneeling difficulty, can persist.
So surgeons weigh these factors.
Exactly. Surgeons weigh these biomechanical pros and cons, alongside patient factors like age, activity level, and specific demands, to make the best choice for that individual.
And for PCL reconstruction, there are also different surgical approaches with biomechanical implications.
Yes, precisely. Comparing the transtibial tunnel technique to the tibial inlay technique for PCL reconstruction. Well, biomechanical studies highlight a significant concern with the transtibial method.
What's that?
The acute angle where the graft exits the tibia tunnel, the killer turn as it's sometimes called, can cause the graft to rub against the bone. This risks graft abrasion and weakening over time.
And the inlay technique avoids this.
Yes, the tibial inlay technique avoids this acute angle by attaching the graft directly onto the back surface of the tibia. Biomechanical tests have shown it provides superior strength after cyclical loading, suggesting potentially better durability. Again, graft choice matters here too. While quadrupled hamstring grafts show high ultimate load to failure, some biomechanical tests suggest they might have less resistance to stretching compared to BPTB grafts when used for the PCL.
There's also increasing interest in adding extra-articular procedures, like a lateral extra-articular tenodesis, LAT, or perhaps an all-anterolateral ligament reconstruction alongside ACL reconstruction, especially for patients with high-grade instability. What's the biomechanical rationale there, and what are the potential downsides?
Right. The biomechanical goal of adding an LET, or all reconstruction, is to provide supplemental restraint on the anterolateral side of the knee.
What does that achieve?
It helps resist anterior tibial translation and also internal rotation, especially at lower flexion angles. It can potentially load share with the ACL graft, theoretically protecting it in high-stress situations like pivoting movements. It's often considered for patients with significant rotational instability, a high pivot shift on examination, or those deemed at high risk of ACL graft re-rupture, like young athletes returning to pivoting sports.
But there are concerns.
Yes, the biomechanical concern is that adding a structure that's tensioned outside the joint's natural axis of rotation could potentially constrain normal knee motion.
Over-constrain it.
Potentially. Studies have shown that while these procedures effectively reduce that pivot shift instability, they can slightly constrain normal knee flexion and internal rotation. This could alter contact pressures, particularly in the lateral compartment of the knee. Techniques that pass the graft deep to the fibular collateral ligament and fix it with the knee in slight flexion around 30 degrees seem to replicate native kinematics better than some older techniques, but they can still minimally constrain motion.
And clinically, do they lead to better results?
Well, clinically, while they improve objective stability measures like the pivot shift, meta-analyses in clinical studies cited in the source often don't show significantly better patient-reported outcomes or return to sport rates compared to isolated ACL reconstruction. However, they are associated with increased complication rates, things like infection or stiffness.
So it's a trade-off.
It's a classic biomechanical trade-off.
Yeah.
You gain some objective stability, but potentially lose some natural motion and introduce other risks. It has to be carefully considered for the right patient.
That's a crucial nuance. Surgery can improve stability, but doesn't always perfectly restore native function or lead to better subjective outcomes for the patient. This seems perhaps even more pronounced in joint replacements. Let's talk about the biomechanics of total knee arthroplasty, or TKA.
Yes, total knee replacement is a truly remarkable procedure for relieving pain and restoring function in arthritic knees. But biomechanically, you're replacing a complex biological system with mechanical components. The design of the implant itself matters significantly.
How so?
More constrained designs, which have more built-in stability between the components, rely less on the patient's remaining ligaments. But they transfer more stress to the bone-implant interface, which can increase the long-term risk of loosening. Less constrained designs rely more on preserving and carefully balancing the patient's own ligaments for stability, aiming for perhaps more natural kinematics, but requiring good soft tissue integrity.
And designs like CR versus PS.
Right. Different designs, like cruciate retaining, CR versus posterior stabilized PS designs, handle the role of the sacrificed PCL differently. This impacts the rollback motion of the femur on the tibia during flexion, which is part of normal knee kinematics.
And getting the alignment right during surgery must be absolutely paramount for load distribution and longevity.
It's absolutely critical. The source highlights different alignment philosophies, like aiming for a straight mechanical axis aligned with the center of the hip, knee, and ankle, versus aiming for a more kinematic alignment, trying to replicate the patient's native pre-arthritic anatomy.
Does the philosophy matter most, or the execution?
Regardless of the philosophy, restoring the appropriate coronal plane alignment, avoiding excessive varus or valgus, and restoring the native joint line height are essential for balancing the soft tissues properly and distributing load evenly across the implant. FEA studies, like the one by Kang et al. Mentioned, clearly show that even small degrees of malalignment in the femoral component can significantly shift the stress distribution on the polyethylene bearing surface and any remaining cartilage. This can lead to uneven wear and potentially earlier failure. Valgus malalignment, in particular, appears detrimental in shifting contact stresses laterally.
What about the biomechanical reality of what patients can actually do after TKA? The textbook suggests they often don't achieve completely normal gait mechanics, is that right?
That's a key point for setting realistic patient expectations. Systematic reviews cited in the source indicate that while TKA dramatically improves function compared to a painful arthritic knee, most patients do not achieve a gait pattern identical to healthy individuals.
How is it different?
They often walk with a reduced range of motion, particularly less knee flexion during the swing phase of gait, and also reduced loading of the operated leg during the stance phase.
And that affects activities.
Yes, this altered gait pattern, along with the inherent mechanical limitations of the implant designs themselves, explains why high-impact or pivoting sports like tennis, basketball, or running remain challenging or generally unadvised. There's just too much risk of loosening or excessive wear. Activities with more predictable, less complex loads like cycling, swimming, or golf are typically much more achievable and recommended.
And this ties into concerns about implant longevity, especially for younger or more active patients receiving a TKA.
Precisely. Higher activity levels generate more load cycles and potentially higher peak forces on the implant components. This leads to increased wear on the polyethylene, insert the plastic liner, and increased stress at the bone implant interface.
And that leads to failure.
This increased wear and stress is believed to contribute significantly to aseptic loosening, which is the most common reason for revision surgery in TKAs. Registry data, such as from the Norwegian Arthroplasty Registry referenced in the text, clearly shows a higher revision risk for younger, more active patients, particularly males under 65. This supports the biomechanical link between activity level, implant loading, and lifespan.
So managing expectations is key.
Absolutely. Surgeons must communicate this reality, guiding patients toward realistic expectations about their potential function and the potential impact of their activity choices on the longevity of their knee replacement.
Lastly, let's just circle back briefly to mechanical loading and tissue healing, specifically in cartilage repair. The source mentions some intriguing, almost conflicting findings from in vitro studies regarding the effects of shear forces.
Yes. This highlights the real subtlety and complexity of mechanobiology, how mechanical stimuli influence biological processes at a cellular level. In the context of cartilage repair, particularly techniques like microfracture, which aim to create a clot that hopefully forms fibrocartilage, there's been interest in the role of mechanical loading, such as using continuous passive motion (CPM) machines after surgery.
What did the studies show?
Some in vitro studies, using cartilage cells or repair tissue constructs in a lab environment, have suggested that applying certain types of mechanical stimulation, including shear forces, could be beneficial. They might stimulate the cells to produce matrix components like proteoglycans or PRG4, which is a lubricating protein. One study by Nugent-Durfus et al. Found this with specific shear stresses.
But other studies found a different or even opposite response.
Yes, that's the intriguing part. Other in vitro studies, perhaps looking at different types of mechanical stimuli or different time points after injury, have shown that mechanical loading, including the fluid shear stress associated with movement, could also upregulate catabolic enzymes, things like matrix metalloproteinases, anagrokinases, ADMTS.
And those break down tissue.
Exactly. These enzymes break down the extracellular matrix. So the same type of stimulus shear stress applied under slightly different conditions or analyzed differently can potentially elicit both anabolic building up and catabolic breaking down responses.
That's a bit counterintuitive, isn't it? It suggests that the precise type, magnitude, duration, and frequency of mechanical load, as well as the specific biological state of the tissue at that time, are absolutely critical.
It's exactly right. This is why translating promising in vitro findings directly into clinical practice is so challenging. While CPM is sometimes used after cartilage repair based on the hypothesis that early movement's beneficial, the clinical evidence supporting its routine use for improving actual cartilage repair outcomes isn't as strong or consistent as those initial in vitro findings might suggest.
So still more to learn.
It underscores that we still have a lot to learn about the optimal mechanical environment for promoting true regeneration rather than just repair in tissues like cartilage.
Yeah.
The interaction between mechanics and biology is incredibly complex.
We've covered a tremendous amount of ground today, really peeling back the layers on orthopedic biomechanics, from the inherent properties of tissues to the intricate mechanics of our joints and the biomechanical realities driving treatment outcomes. Before we wrap up, could you share maybe a couple of your most memorable quick hits or facts from this source material?
Certainly. One that always sticks with me is that the iliofemoral ligament, one of the key stabilizers in the hip, is actually biomechanically the strongest ligament in the entire human body. Quite impressive.
Wow, I didn't know that.
Another is the versatility of finite element analysis, seeing a tool originally developed for analyzing bridges now being routinely used to understand the intricate mechanics of a hip implant or a reconstructed knee.
That's quite a leap.
It is. And then those striking statistics we discussed earlier, freeze-drying bone grafts, potentially reducing their mechanical strength by 20%, and that incredible 1 millimeter talar shift reducing ankle contact area by 42%. They're just powerful reminders of the precision involved and how small changes can have big consequences.
Those details truly highlight the deep dive nature of this material. For our listener, perhaps a mid to senior professional navigating various industries, what would you say are the core takeaways from this exploration?
Well, I think firstly, understanding orthopedic biomechanics provides a fundamental framework. It helps comprehend injury mechanisms, the rationale behind different treatment approaches, and the challenges of recovery. And that knowledge is valuable whether you're involved in healthcare directly, medical devices, insurance, sports management, or related fields.
Sure.
Secondly, every orthopedic intervention, from grafting tissues to implanting joints, involves specific biomechanical trade-offs. There's rarely a perfect solution that fully replicates native function, and understanding these compromises is absolutely key to setting realistic expectations for patients and for product development.
Right.
Thirdly, advanced analytical tools like FEA are transforming our ability to understand complex biological systems and predict the outcomes of interventions. This marks a clear direction for the future of the field, even though translating this fully into routine clinical practice takes time and effort.
Makes sense.
And fourthly, perhaps most fundamentally, the inherent complexity and delicate balance of static and dynamic stability within our joints mean that seemingly minor injuries can have significant cascading biomechanical effects. This can predispose individuals to long-term issues if not addressed with that biomechanical understanding firmly in mind.
That's a fantastic summary. Thank you so much for guiding us through this complex yet utterly fascinating subject today.
My pleasure. It's a field I'm passionate about.
If you found this deep dive insightful, please consider rating and sharing the show. It really helps others discover valuable knowledge. As we continue to advance our understanding and develop new technologies in orthopedics, that central challenge seems to remain. Can we truly perfectly replicate the complex, dynamic biomechanics of a healthy, living human joint?
The ultimate goal.
And if not, or perhaps not yet, what does that fundamental limitation mean for the ultimate potential of restoring full mobility and function after injury or disease? Something to ponder. You can explore these questions further by diving into comprehensive texts on orthopedic biomechanics like the one that guided our discussion today. Until next time, keep diving deep.